have an opportunity to present, and I always want to sort of say up front before I get carried away and get talking that I'm just the front man of this. And so I'm pretty persistent in saying that the babies need to have services, but this is just me presenting the work that the whole team is doing. And it's funny because, or fortuitous, because I just had another article come across my desk. Once you start looking for interprofessional collaborative practice, all of a sudden it starts to become, oh, I see it everywhere I look. So we started these ACH feeding rounds a year ago in January, like January 2020, and against all odds, everything we've lived through COVID, and it's going forward. And so I'd send out a note because we had a little guy come through NICU. I've been an NP for a long time, and I really thought this was a well highlighted piece of good work that the entire team did. Everybody who touched this baby across several sites, several units, multidiscipline, and I sent a note around, and then Melanie said, oh, will you be willing to share this story? So that's what this is. This is not actually our little guy. This is a baby of a similar gestation, and that's kind of what he would have looked like when he was sick in the NICU. And this is just a little fellow that I have permission to use his photo, but this is a similar kind of gestation. So you see teeny tiny to start out with, and lots of tubes and business for those of you who aren't in the NICU. And then he's born at 23 weeks. So like he's just barely even made half, just past halfway of what his gestation should be to be at term. And then the next slide will tell you that, in addition to prematurity, which is, I think, a big enough problem on its own, honestly, he has all kinds of comorbidities, this poor little guy. So he has a brain injury, and he ended up with post-hemorrhagic hydrocephalus. He needed neurosurgery, and that's how he ended up being transferred to ACH NICU. Had a long ventilation course, 34 days, which is pretty long in these days. Needed 2 courses of steroids to facilitate extubation. He ended up with rip-roaring bronchopulmonary dysplasia. He had terrible retinopathy of prematurity, ended up with 1 infection. So all in all, he's got lots of little comorbidities in addition to just being a prem. If you want to just slip the next slide up, that would be great. And oopsie, if you go back, again, this is just a baby at a similar gestation, and when we talk about sync or early tasting, and it's an algorithm that we're using here and some other places as well, but this is what he would have looked like. Lots of CPAP support, having a pacifier, and just being sort of bundled and supported and side-lying and all that kind of business. And so sync B is just early tasting. And I just wanted to give you a reference of what that would look like. And then the next slide is, so sync B, this is drops of his mom's own milk, is what MOM is, of course, beside a pacifier. And I think one of the things that's super interesting about this is that he had an interprofessional team, and people were willing to tolerate this. And so this is when I think we're really winning with eating as a neurodevelopmental task, that somebody didn't get in a fuss and go, oh my God, he's 38 weeks or he's 40 weeks or we're losing the window, whatever that is, to learn to eat, and didn't just whip out a bottle and start trying to feed him, and instead met him in terms of his respiratory troubles and his amount of fatigue and all the other things he needed to get over. And so they did this for 9 weeks. They were willing to modify him to just have these little tiny drops of milk. And sometimes it was like a maximum of 0.5 mils out of a 60 mil feed. And he was seen by the whole team, and everyone was in agreement, and everybody bought into this program for him, which isn't always the case, which you're probably getting from the tone of what I'm telling you. So this idea to have this patience while he's developing, and sometimes he'd be like, oh, he can't have anything by mouth. He's sick. He's not feeling well. And so this ability to sit still and wait for the baby to meet us was really remarkable, in my opinion. The next one. And so we were lucky enough to start this team in the children's sort of almost as a pilot, and we've had lots of support from all the discipline leads to be able to do so. So we've got SLP, OT, lactation consultant, the bedside nurses, the neonatologist, myself, dietitian, big team walk around every week, and we meet once a week, and then there's all the other things, and just sort of review all the babies and say who needs what, and is there anybody we're missing, and do we have plans in place. But anyway, this is a little note because I hate to do anything without evidence, but optimizing interprofessional practice has been identified as one of the key methods for improving health outcomes, which is what I believe in. And so this collaborative practice, when we get together, everybody with these different lenses and this different ability to focus. I mean, this is when we start to deliver, I think, the highest quality of care. And it's not just me that thinks that. Um, it's like several references as well, and so I like to present things that can be referenced. But anyway, and we can engage any individual whose skills might help us to achieve what we need. And I think that's what we've been doing while we started this in January, instead of sort of a hit and miss approach and leaving babies too late and those kinds of things, trying to get up front. And then also we're working on some deliverables. I think that could go to the next slide, Vanessa. So yeah, there's the team. The respiratory therapists, I need to do more about engaging them. What we're still trying to have people understand more about, and that's why they're not as bolded, but eating and breathing are related activities. And so like they're more peripherally involved right now, but all the nurses and like the medical line is long, right? Because this is all the people that come in contact with the babies. And so to have everyone follow the plan and stick to the script is kind of amazing when we think about it. And then here's the other people that I was mentioning, and then the family to engage. And I mean, you could put them at the top and it wouldn't be wrong, but this idea that you figure out what their plan is as well, and then try and engage them and try and work on this so that, there's no plan that can be executed well if the family has an intention to do something completely different, or, will do what they want to when they go home anyway. So next slide. And so what I'm super proud about this work of this team is that they followed this baby's lead for all of that time, and he did these tiny little modified bits of food. And then as he matured and got his breathing better and all the rest of his head got better and all kinds of things were like working in his favor, he transitioned out of NICU, which I think is remarkable in fact that he had a discharge plan from NICU for feeding, and it was in place and it was followed when he left. And that also speaks to that interprofessional team following him through the hospital. They worked on his strengths, and it ended up being that his strength was breastfeeding, not bottle feeding. And so the family was like in this in terms of that was their bigger plan as well. So the mom came and stayed, and anyway, family goal supported. And he went home at 45 weeks after 22 weeks in the hospital with exclusive breastfeeding. And so I sent around the note when I did that, because I went, oh my God, I never thought, I actually have to confess, I didn't think he was going to learn to eat at some point around 36 weeks where he's still, 0.1 of a mil at times, nothing for several days in a row. Okay, and then the next slide. And then I just don't want you to think that we're all sitting around here thinking how amazing the work is that we do, because I think there is also a piece of continuity of care following discharge. And so we phoned to find out. So he left here with like pretty sketchy, I would call them sketchy bottle feeding skills. And in that he was taking partial bottles, and we sent him home without an NG because he was gaining weight beautifully with breastfeeding only, and seemed like all his minerals and his bone mineralization all looked okay to do that. And then I think there is a piece of this about what happens in the continuity of care after they leave the hospital as well. And so I'm working on this with the team as well, that we are trying to say you should leave with a written discharge feeding plan, like you wouldn't have a wisdom tooth out and not leave with a written discharge plan. So more of that. But when we phoned the family, they'd been home for a little bit, and who knows what the motivation is, because we have lots of trouble exploring that with different families. But they'd initiated bottle feeding after they got home, when we thought their goal was always to do breastfeeding. So he's okay, that I can see that he's still gaining weight and he's still doing breast and bottle feeding. But I don't think that we are just 100% there, even though we've got a nice success story out of getting out of the hospital. Again, this need to clarify all the time with family goals, and in this case, language was a concern in that English was not first language. And then I think this ongoing support, like, are we all clear as a team about what we're trying to accomplish? And I don't think that's always the case. And so I think that's probably what we're thinking that we're doing not too badly at least in the NICU and maybe in the hospital now, but like we have lots more to do in terms of continuity after leaving the hospital. Anyway, I think that's all I wanted to say about the great work of the entire team, because it takes it's the OTs, SLPs, lactation consultants, every single nurse who touches that baby, the medical team that is willing to follow along with a plan, the fact that we're trying to make a clear plan that's sort of based in evidence and neurodevelopmentally supported. So that's my story. And I think I'm going to even have a few minutes for questions if Vanessa thinks I've done okay.
Absolutely. Yeah, thank you so much. We definitely have like five minutes for questions for sure.
Yeah, sure.
Yeah. I think there's a few questions in the sidebar even, and Tricia, if you want to facilitate those or have, go for it.
Absolutely. Stacey, thank you so much. I was inspired by your sharing and how the teams developed over time. I think I saw January 2020 was kind of the go date. Cheryl Brown is in Peace Collaborative area. She's asking if this approach is consistent across the province. So if other zones, other representatives could comment, that'd be great. And I guess while we everybody
think about that.
Yeah, I guess I'll start, Cheryl. In the south, for like one of our regional hospitals, our speech pathology, OT, and dietitian are very involved with the NICU. I should say it is more speech and dietitian, but certainly OT is involved, you know, as a team member. The nurses and the medical specialists are also very involved as a team. I can't speak as much for Chinook Regional Hospital. We are trying to get our legs and momentum together under this PEAS Innovation Learning Collaborative to do more teamwork. So that's the South update. Julia's mentioned here, what a great example of multidisciplinary team care, and Winnie too, just great work.
Stacey, I love your story, and I think it highlights a lot of it's Julia.
Hi, Julia.
Hi, nice to talk to you.
Yeah, I'm rooting for you all the time.
It highlights a lot of the challenges that we have and the opportunities we have, and I think it to get everybody together and talk about individual patients is a challenge, but kudos to you for doing it, because it takes just setting it aside and making it a priority. To answer your question, Cheryl, about as far as I know, in Edmonton, we do not do feeding rounds in the same way. I think there might be an opportunity in some of our smaller centers, such as the Stollery David Schiff NICU, where we have fewer numbers of beds and fewer patients feeding, and where certainly the patient needs change quite drastically. I think that would be similar to what you're seeing, Stacey, in terms of Alberta Children's Hospital. I think here at the Alex, with 69 beds, it would be really difficult. We wouldn't possibly be able to see 69 patients in once a week rounds. So we have 3 dietitians on 3 different teams. We have 7 lactation consultants, and we have 1 SLP. So our approach is really that we, for babies that have complex needs, and all babies go through a similar program as you have, Stacey, the SYNC program, which we have modified as poetry for our very premature babies. And then what I find, like you said, is if you have consistent opportunities that are developmentally appropriate and provided in keeping with a baby's current abilities, they actually do really, really well. And I don't often need to see them for trouble feeding at the end of their stay. So babies who are continuing to need support have a feeding plan at discharge. And other than that, they pretty much go home with hopefully something they're already comfortable doing. One of the things we have certainly thought about having a feeding rounds with lactation consultants, dietitian, and SLP, but just logistically, it's kind of hard to wrap our brains around here.
Yeah, I think there's one question about, is this going to be in other NICUs? And I know that Foothills is looking at this, and I think the same conversation is like, you're right, Julia, it's a small unit here. And not every baby needs services. Like some of them, we're like, yeah, so-and-so is in sync, the nurses are doing great. Does anybody have any questions? Like that part has been really good, to allow nurses to ask the OTs and SLPs, or to have some individualized coaching, or have somebody else weighed in with another lens. Like that's been very, very helpful. And I think it wouldn't be every baby, like certainly at Foothills when I was there, there's a handful of kids that don't eat, a handful of kids that are too pram, like that kind of thing. And so I think it is going to be, if they adopt this similar sort of model, it's going to be just, a review of like, is everybody getting the services that they need? And does everybody have a discharge feeding plan that, in writing what you're using, how you're doing it, that helps parents negotiate all those things when they get home.
Absolutely. I think that's so great to do it at bedside. And if you could select the few patients that would really need it and benefit from that combined approach, I think it would be really useful. We do meet once a week in our interdisciplinary team rounds, something we started a couple years ago out of necessity, to just get an update on every single baby on the unit. So the lactation consultant, occupational therapist, speech language pathologist, child health worker, and head nurses meet once a week to just update. So, and it has proven so important, because we get to focus on feeding in that time and just talk about where families are. But that being able to go in and implement that plan at bedside together would be amazing.
I see a question about this discharge feeding plan is something that we're just trialing and mucking around with. We've got 3 different versions right now. One if you're an exclusive breastfeeding baby, one if you're doing a combination, and one if you're straight up bottle fed. And what we've been doing is giving them to the family and saying, like, this is your, like, if somebody's asking you to do something completely different, and I do think there's a lot of good intention to, that can really tip the apple cart once they get home. We get babies coming back even for hernia repair who've jumped up 3 levels of flow. Like there's just a lot of bad good advice, I guess, that from neighbors, and I'm not even talking healthcare professionals all the time, but anyway, I think that this discharge plan is maybe like something more, and this continuity of peace is one thing that we need to work on more.
Agreed. We certainly see a lot of transfers between sites, and when you have very, very different approaches between sites, it can be a real change. Is hard for families, even just moving their baby across the city, and then to have something where they don't recognize what they're seeing as familiar, or it can be really difficult for sure. Meredith, I feel your pain.
It was an enlightening experience.
Yeah, I'm sitting on the edge of my chair. Well, so what I can tell you is SYNC has only been around since 2014, and this idea of eating as a neurodevelopmental task, like not everybody has bought into this, that there's still, and you heard me hint around that we sometimes feed by gestation or feed by our expectations, or like it can be pretty tricky, honestly. And I only can say that it's just going to get better over time as, new neonatologists, new nurses, like we're working to publish more, like that sort of thing, where I think the evidence is coming. But yeah, it's a process.
Thank you for starting.
Oh, well. Eek.
Yeah, it is inspiring, right? To, the discussion and the comments that come out of a presentation and an update like this, Stacey. It's such valuable sharing, right? To see how services can evolve and continuously improve for the family and the infant. Yeah, it's promising. We so value your time.
Oh, thanks, Tricia. I would say, like, 2 things that I didn't mention, that Dr. Alex Howlett is a sponsor of this, and like without her as the site leader for neonatology at Children's NICU, who has, as she say, bought into this whole thing about feeding that you're on about, Stacey. Like it's become a clinical interest for her. So without her supporting this, we would never have been able to do this, as well as all the discipline leads. But I do think that the more that we we use the word expose, but the more we highlight that there is good work that can be done like this in these multiple lenses, and when we work together and when we put the family and the baby at the forefront of our efforts, which is why the whole building is here, then like we won't be able to go wrong, honestly.
Mm-hmm. Yeah, good point, Stace. And I see Vanessa's pulling up the resources that are on the PEAS website for forms. Go ahead.
Yeah, I was just curious. We have this pediatric oral feeding care plan, and we're working on an enteral feeding care plan as well. But I'm not sure if you've had a chance to look at it, and I'm curious if it would be helpful in terms of the discharge planning process and using a form that's already out there. So this is what we created for outpatient and community care. But of course, transitioning from NICU to home might be appropriate to look at something like this. So
I did see that, Vanessa, and of course, like all of that isn't like they're not doing any of that out of the NICU. Like,
okay,
everything is thin. Like, so I think, yes, I think that it would be amazing to have a form that would be more consistently used across, where everyone would eventually know to look. But I think that's it's too pediatric probably for us.
Okay, yeah. No, that's totally fair.
I agree. A form that can be updated as changes make, because I think right now we get bogged down with going back and trying to hunt and find the documents, and that's why people aren't on the same page.
Yeah.
Well, and we're not all in agreement about how babies should be fed. Like, I'll just say it. So there are still people who believe that, we should have a faster flow bottle, and like that's like the 1980s thinking, and it just ran into them, and sure, the volume got in. And so there's still we're still not there as as healthcare professionals across the board. I'm not talking about SLPs and OTs. I'm talking about other people. That's what we did in the 80s. We got the fastest flow we could. And, and it just ran into them, and it eventually didn't work out very well for many, many kids. It was a sink or swim performance for them, and didn't
and a lot of oral aversion because of it.
Yeah, it didn't build any fundamental steps, that's for sure. And I do think some kids survived. And I also think out of NICU, we've been extraordinarily guilty of, get you to the door and see ya, wouldn't want to be ya, as I call it. Like you left feeding, and that was all you were doing, but we don't really, we didn't care what happened after the fact, because you weren't our patient anymore. And I keep harping about that, this long term, this continuity, this what's happening to you in your life. And we're not good at that yet.
And Stacey, do you use the Connect Care form for infant feeding or nipple fed infants? There is something developed for Connect Care, but can be utilized outside of Connect Care as well, like all the elements. And I know Beverly Collison's been very involved with that development. So I don't know for others on the line too.
I'll look forward to Connect Care.
Yeah. You and us both, Stacey. Trisha, as I understood it, that was still in the build stage. Has it been built into Connect Care?
I don't believe so. It was
yeah, we were. I was on the committee that built that. It took us 2 years to build an infant feeding protocol for Connect Care, and then we were told that it was on the back burner because it wasn't primary care. And so we were quite frustrated, and I actually mentioned that to Heather Chinnery just in passing in the halls one day, and she said, I have Joseanne, and she can build that for us. So they just started on their very own. So as far as I know, that's just been spearheaded, and we're really hoping to have it. I'd love to. I'll send it to you, Stacey, the most recent version I have, which is version 15. And what I find which I'm really hopeful about once it comes out, and I'm hoping they have it by the time, Stacey, you and I have to enter into Connect Care, is that it will actually generate a discharge plan. So it will show how a baby has progressed through feeding, through all of the different stages and at different times, and what the feeding plan was like originally. So what flow rate, what breastfeeding started with, how it went
Amazing.
on during the stay, and then show that journey at the end, so that other practitioners, like our people who have these babies as outpatients, will have a sense of their whole journey, not just a single view of what happened right as they were leaving home for home.
Yeah.
Again, so promising. Thanks for sharing, Julia. And with your group having worked on that, is it your understanding too that that can be shared out as so that departments in other zones that are not on Connect Care can kind of use it as their own paper process, right? Like kind of develop our own paper process?
Certainly, I think it's 22 pages long on paper. So it's not really made for paper. You know, it has lots of drop down fields that you can select from, and then condenses in a report. So if someone wanted to use it to generate a report, I imagine there's a lot of rich information in it. We pulled from a number of sources, including any pediatric assessment tools out there, to try to capture everything. And Sync is on there, and Poetry is on there, and a whole bunch of different things. So, yeah, it would be difficult to use it as a paper copy, I would think, right now. But the information in it certainly could be used.
Yeah, just as a guide, right? The algorithms and
Okay. Yeah, and I do think, like, Julia's point is really well taken. I do think that these babies show up, and like this little guy I presented to you, like he's 4 kilos at term, and it's very tough to receive him and go like, what are you, like dumb that you can't eat, like you're this great big baby? And so that there's this sort of this whole lack of understanding through nobody's fault many times, that this big baby has got all of these past morbidities that would affect. And if we ever put on that, that set of glasses and sort of thought like, wow, if I'd been through all these things this baby had, like I'd be having sips of ginger ale if I were lucky, And so I think that this idea of us seeing the journey and understanding what it's taken to get there, because many times we get to the end of the sink, and I don't know if it's like that for you, Julia, with Poetry, but everybody's like, well, that's done now, so now you can just eat. And I'm like, no, like you had this 100 little baby steps to get here, like you're just doing it, like it's going to be ages before you're just able to eat. Like there's so much care and attention that's still required. And
it's true. We get our, I often think about it when we're sending families home, is that you no longer need intensive care. That's why you are leaving the NICU, but you still have a lot of other needs, and you, like you said, you've just reached to the point where you can take full oral feeds. You're just stable enough to leave. Does that mean that you are going to be like every other term baby out there? No.
Yeah.
So I think there's certainly a lot of teaching that has to happen, and I agree with you, Stacey. We do have a long ways to go in terms of teaching each other about expectations, and teaching families, and so I think having a group together, one of the great benefits that you would have in doing that is the consistency and not changing the plan 100 times in those last weeks before discharge.
I'm wondering if we can take this forward as part of our between our ILCs, Vanessa, where we have this kind of sharing. I just think this is so rich.
Absolutely.
Yeah. So thank you, Stacey, and thank you, everyone, right? I've never seen that flow of comments in a meeting. That it's, again, just applauds the efforts and the work that's been done for babies and their families. It kind of chokes me up, to be honest. So thank you so much for sharing. And if it's okay with everybody, I'm going to turn it back to Vanessa.
Yeah, thanks so much. And Stacey, I actually hit the record button because
Oh,
I knew that this was going to be a great presentation. I was hoping that we could, if you're okay with it, share it with the other team members that weren't able to attend today.
Yeah, I don't think I said anything too controversial, so or nothing that I wouldn't repeat. So yeah, you go ahead.
Love it. Thank you so much, Stacey.
Okay, thanks.
Feel free to stay on the line or
Oh, I'm
jump
running
off the
back
call.
to clinical. I'm like miles behind, but thank you so much.
Thanks.
Thanks.
Okay.